Welcome, everyone. My name is Jenny Hornick, and I'm the Digital Marketing Specialist here at JMIR Publications. And I'm very excited to welcome you to another of our monthly editions of the Society of Digital Psychiatry and JMIR Mental Health webinar series. So today's topic is a very interesting one. It's going to be on technology and eating disorders care, where we are and what lies ahead. So we'll dive into that in just a moment, but before we do, I just have a couple of housekeeping items I wanted to highlight. So firstly, you'll notice that all of your microphones are muted and they will stay muted for the duration of the session. But if you do have a question for our speakers, you can drop it into the Q&A box, which you'll find at the bottom of your screen, and we'll have a designated Q&A session at the later half of the webinar. I also just want to let everyone know that this session is being recorded and the recording will become available on our YouTube channel early next week. So that's all from me. So I would like everyone to join me in welcoming Dr. John Torous to kick things off for us. So Dr. Torous is the director of the Digital Psychiatry Division at Beth Israel Deaconess Medical Center, affiliated teaching hospital of Harvard Medical School. He's also, of course, the editor-in-chief of JMIR Mental Health. So without further ado, I'll pass things over to you, John.
Thank you, Jenny, and to JMIR and Society of Digital Psychiatry. I'm excited to introduce our fantastic speaker, Laura Damo, who's a MS, but currently a clinical psychology doctoral candidate. So soon, much more at Drexel University. And her research is fascinating. It focuses on developing, testing, and implementing really a range of different digital-based interventions for eating disorders and related mental health conditions, with the goal of expanding access to care. And we know this is a hot topic. We've covered aspects of it in prior webinars, but I think what makes Laura's work so fantastic is it really spans a broad range of, in part, technologies, populations, but it's very thoughtful in approaching this, again, challenging but necessary area for innovation. So maybe, Laura, to kick us off in background, what is the current clinical state of treatments for eating disorders today? It's probably not going to be great, but let's see where we are in mid 2025.
Yeah, well, thank you so much for the introduction, and thanks everyone for being here and for organizing this webinar. The current clinical state of eating disorders. So first of all, let me just say eating disorders are of course, very serious, sometimes deadly conditions, and they're very common and increasing in prevalence, which is very concerning. The current state of things is that we have some well-established evidence-based treatments. The big downside that you're probably expecting me to say is that there's a huge treatment gap. The vast majority of people with eating disorders don't get any care. They don't even have their eating disorders diagnosed or identified in the first place because of tons of barriers, lack of access to care, cost, not having insurance coverage, provider shortages, stigma, not thinking their symptoms are serious enough to warrant treatment. And so I think technology is really exciting because of its potential to try to bridge some of those gaps to provide more scalable support to people who otherwise are not getting into the traditional settings.
Yeah. It's been an area I think we've seen a lot of innovation in technology happening. And there's a lot of ways to categorize or think about these innovations in technology. But if we take a very simple approach of some of these technologies help us monitor, screen, and diagnose, some of them help us treat, intervene, or do actions from kind of just, again, you being in the field, seeing all these things happening, what are the most promising kind of health technology? We'll include AI even in this approaches towards, maybe we can cover the monitoring first, and we'll come back and talk about what you see on the intervention side.
Okay. Yeah, the most promising approaches. Yeah, so maybe before we go into like ongoing monitoring, I'll just say a word about screening, because I really do think there's a place for digital tools in the screening world. And I think that's like so needed. So screening and early identification, right, is so critical. And technology has really started to make screening a lot more efficient, more personalized. And, we now luckily have a couple of big public-facing, free to access online screens that anyone can use if they're, interested in learning more. So there's the National Eating Disorders Association online screen, and in Australia, there's one called the Inside Out Screener. Both of these are evidence-based and validated screens that they're really cool because of the technology capacity. They give you instant feedback on what you're screening positive for, and then can instantly give you referrals to treatment. So I think that has a lot of potential to really bridge the gap. And digital screens obviously have the potential to be embedded into healthcare systems and primary care, in universities and school systems. So wanted to say a little bit about that. For ongoing monitoring, that's actually a really interesting area that's seen a ton of innovation, I think, in the past couple of years. So I would say for the past decade or so, our field has been interested in, daily diaries and experience sampling, ecological momentary assessment, right? So that's that real-time self-reporting on disordered eating behaviors, and then also associated behaviors or other metrics, mood, body image, things like that, that in the moment could be triggering disordered eating behavior engagement. More recently, though, we've kind of advanced to things like passive sensors and wearables, where you can use data collected from those things, heart rate, sleep, et cetera, to really try to detect and predict I guess, early warning signs. And the potential there is huge, right? Because then you could pair that with some like just-in-time adaptive interventions and really try to give support when it's needed. So I think there's a ton of innovation on that front.
And even the screening is really important. There's a doctoral candidate in our team, Jenny Nowicki, and she's been adding the MSCOF, which is kind of, again, a early screening assessment, but it's impressive how many people may be at risk. Even forward that we can pick up that in some ways our healthcare systems may be blind to, because you're right, we don't want to pick up people when they have to come to an emergency department because we've reached many stages into the illness where it's more severe. And it's exciting to see that whole range from, as you said, kind of real-time sensors to screening in it. And it's nice that there's a chance for this innovation to happen. And you alluded to it with these just-in-time adaptive interventions. I've never understood the word Jedi. Sometimes people call it that, but we're going to call it just-in-time adaptive interventions. But maybe we can start with what are these interventions that could exist that technology could do, and we can include these just-in-time adaptive interventions.
Yeah. Yeah, well, there are a lot of different ways of intervening. It's ever expanding, right? And AI only makes things even more endlessly possible, right? So I tend to categorize digital interventions for eating disorders in my mind into like, the self-guided kind of self-help programs, and then, those that involve some human support. On the self-guided front, right, we have apps, and there are some nice apps being developed that are, distilling down some CBT skills that are evidence-based, self-monitoring functionality, which is really critical for eating disorder treatment, skills content. And, I think there's a place for that, definitely in prevention and, lower severity symptoms. And then you have coached digital programs or like blended programs with some amount of human support, which varies a lot. And yeah, again, like very scalable. As we get into chatbots, which are clearly all the rage right now,
Yes, they are.
there are, yeah, we'd love to talk about them. There are the rule-based chatbots, right? So this is something that's getting a ton of attention. Now the generative AI is coming in, but rule-based chatbots, right, have shown some effectiveness in the areas of like prevention, also trying to connect. I was involved with some work led by Dr. Ellen Fitzsimmons-Craft, where she developed a rule-based chatbot to try to intervene further up the chain. So trying to get people who completed an online screener and screened positive for an eating disorder, giving them a chatbot so that they could, that did some motivational interviewing and things like that to try to get them to seek treatment. So trying to intervene earlier. So I think that's, a big advantage. And the advantage of those too is like, they're very interactive, right? They are more human-like, which could keep people engaged the ever
Yeah.
present engagement problem. And then there are the just-in-time adaptive interventions, which are supposed to intervene in the moment based on those like sensor or, otherwise like self-report data streams. And then there's Gen AI, which is a whole new world that we don't know very well yet, but it's coming. And yeah, we can talk about that, but that's definitely on the horizon.
No, it's such a large spectrum. It's almost very hard to keep up with all of it. I know in Australia, I do some work. I'll put a reference with Jake Linnerdon. He's put a perspective on it. Gemma Sharp just had an RCT come out of a brand new AI agent. But again, this is within weeks, this research, and I put the links in the chat. We'll put in a chat for everyone. But again, there's a lot coming out. And maybe, Laura, you could tell us about your own research, and I'll share those links in it because that's the one you'll have even more insights into kind of what you're working on and what excites you.
Yeah. Yeah, so right now I'm a little preoccupied with my dissertation. That's the stage of grad school that I'm in. I'm actually doing, an old-fashioned ecological momentary assessment study with teens who have eating disorders, trying to get really fine-grained data on, moment to moment, what's going on with them interpersonally, mood-wise, et cetera. What are they doing on social media? Like things that I think could really be predicting engagement in disordered eating behaviors. I'm hoping to inform some just-in-time adaptive interventions. And then we're also going to run some idiographic models. So I should say too, like there's a ton of opportunity with these tools to do really personalized interventions. So hoping to figure out how to predict individual risk based on what I gather from the EMA data and then create personalized interventions, which would be
Laura, just for everyone listening, idiographic would be kind of within person or
Yep, exactly.
okay.
Per person. Yep.
Because it does make sense. It's never easy to build a predictive model, but you can sometimes do one for a population because you have so much data. But in essence, we need to help each person where they are. And maybe you could explain what are the challenges in building these personal or idiographic models that you're seeing as someone doing it hands-on?
Yeah. Well, follow up with me in a year when I actually do the analyses, and I'll tell you how challenging it is. But I can imagine. But yeah, I think it's something we have to grapple with, right? Because, and clearly, I think it's needed because all of the models that we have. Oh, thank you for sharing the papers. All of the models that we have about eating disorder treatments are based on populations, right? And I think they're doing an okay job, but they're missing the mark a lot of the time. I think it was something like, 40% or something like that of people who receive our best treatments don't respond. I think that's based on Jake Leonardon's papers. Or don't remit rather. So clearly we're missing the mark on things. And I think that is partly because a lot of these processes are highly individual. And what triggers disordered eating in one person might not, just do the same thing for the next. So that's where my interest in that is coming from.
Yeah. And are you finding just again in doing the research, working with people hands-on, are people excited to share this information? Are they worried about sharing it? Are they sharing too much?
About like eating pathology?
Eating pathology, or is it hard to even get them to take the surveys or EMA?
I actually don't see that as much. In this type of work, we do have more like human, like participant facing components. And so I think that does increase trust. We could talk about how in some of the work that I've done that has not had that like face-to-face clinical component during an assessment or what have you, there is a little bit more mistrust, right? Because people are cautious about the use of their data in these, digital technology studies, which makes a lot of sense. How is what I'm saying to this chatbot going to be used, and like where is it being put into the ether, and privacy concerns and things.
No, those are valid concerns, and
Mhm.
I do agree with you. It seems like having some human in the loop is the new buzzword, but some level of human support does seem to make these things work a lot better, even if you could, in theory,
Mhm.
automate it all. But maybe that brings me to my next question, just of challenges. Again, even from disordered eating through eating disorders, these are serious conditions. They can be fatal, as you said, of psychiatric conditions. They have some of the highest mortality. So there's definitely going to be risks and challenges. But as we move into this technology space and relatively rapidly too,
Yeah.
what are the challenges that you're seeing or that you would want everyone else who wants to begin doing research in this space to be aware of? Because it's certainly not easy, I imagine.
Mhm. Yeah, I actually I want to talk about this in the context of generative AI, right? Because I think that's what most people are interested in these days. So first I'll say like the potential benefits of using this. I feel like the eating disorder field is being very cautious, as we should be right now, about integration of these tools into our work and into care. Um, right? These are very serious conditions, as you said. The potential benefits are, there are many, right? Like flexibility, personalization, available 24/7, the ability to make good clinical decisions that are just like those of a clinician. And right, there are very serious ethical considerations to take into account. Already started talking about privacy. There's also the potential, depending on how these models are trained, for them to really not give something that is evidence-based. And so I think that's all the more reason for clinicians and experts in the field to be involved in the designing, development, the fine-tuning, and the supervision of these tools, making sure that we are prioritizing safety and transparency. But I will say, people are already turning to ChatGPT for mental health advice all the
Yes.
time. Right. And so it's coming, like it's here. And so I think that we should get in on helping to make sure that these tools are safe and we're being transparent. I don't think they can ever replace humans, but I think they do have potential to be, one tool in the menu of options, right? And certainly, if trained correctly and supervised closely, are better than, or could be better than no care at all.
Yeah. No, it's the topic of the year and probably the next year. In the next year on these generative AI bots, and it is impressive how many people may be turning to them already. And I think again, you've partially answered that question of will generative AI be
Mhm.
helping or hurting, and what is that balance? And I don't think it's for you and me to figure it out, but do you have a sense of kind of where we need to be to make that balance make more sense? Clearly, more research. Would we need international safety protocols? Would we need a universal testing one? Or like if you had unlimited resources, what would you be building to kind of move it forward that you feel comfortable with it?
Yeah. Yeah. Well, I think that one thing that I think as a field, have to move into if we really want to have a say in this work and build really ethical and safe tools is a lot of um, cross-sector collaboration, right? So, personally, do I know the ins and outs of how all of these models work? No, and that's why I need to build the collaborations with the people who do. Um, I think so that's really needed. I think that the clinicians and people with lived experience need to be involved in the testing. Um, Clinical psychologists are going to be the ones, who are seeing these patients, are going to be the ones to we're going to want to run some concordance studies, right, to see how decision making from these tools compares to the actual clinician with all of the experience. So I think a lot of collaboration, obviously, a very close eye and monitoring, and I don't know how much, fine tuning will be involved in actually the building of the models, but probably creating some standards around that will be important for sure.
Yeah. And a lot of people, again, for good reason, also want to enter the technology development space and this place, the research spot.
Mhm.
It's a huge need that we need to fill, and we need more people. What advice do you have for people listening that want to begin a career in this space doing some evidence generation or research? You've
Mhm.
been successful and made it work, but what could you tell people who want to follow in your footsteps?
Yeah. Yeah. Well, I think I'll say again, like collaboration is absolutely key. And I think one thing that our field has struggled with a bit, as many do, is being a little bit siloed. So, I think building collaborations to the extent that you're able to, as a trainee, which can sometimes be hard, with people outside of your field, right? The computer scientists, not just eating disorder researchers, people in industry, right? Those who are capable of building these tools a lot faster than we are, having partners in the community, right? Where you're trying to figure out like what the need really is from people on the ground. I think working across disciplines and really wanting to do that is going to be really helpful. One thing I haven't said so far, but that I try to carry through all my work is I really try to prioritize thinking creatively about implementation. Um, I do think that right now we are starting to run into the same issue with tools, mental health tools that we run into with traditional healthcare systems, which is we have a lot to offer and nobody can access it. And so for anybody who's interested in getting into this space, I would start thinking creatively from the very beginning, about not just, what tool you want to create, but where you think it will live. Think creatively about implementation, how to deploy these things much more broadly within and outside of the traditional healthcare systems, so that you can have a broader impact.
That makes sense, and in part that not that any digital tool is easy to build, but it's maybe cheaper than, say, developing a new drug from scratch. But then you do have to test it in the real world and see how it implements
Absolutely. Yes.
as part two. I want to save time for questions. Again, this perhaps isn't a final question, but perhaps some people listening are seeking help to learn more about eating disorders. Clearly, we're not offering clinical advice here. You shared some good resources, but where are some places people can maybe turn to look for help today? Because a lot of these technologies are developing, but as we said, we're not telling anyone to turn to a chatbot today.
Right. Yes. So I'll give you two resources that I think are great accessible entry points for help. The first is the National Eating Disorders Association website, NEDA. They have, as I said, their publicly available screen with immediate feedback and resources. They also have a tool for finding a treatment provider near you.
Ah,
And otherwise just a ton of resources. The second one is ANAD. I believe it's the Association of Anorexia Nervosa and Associated Disorders. Similarly, has a ton of resources, and they also have free peer-led support groups
okay.
for people struggling with eating disorders.
Those are two fantastic resources for people. And now we have a couple of great questions in. We have about 6 minutes or so for questions. So this first one is saying, given that just-in-time adaptive interventions, again, hinge on having really accurate information. You're going to tell someone in real time what to do. You need to know what's happening. And sometimes the predictive accuracy of these smartphone biomarkers we're all learning together. Sometimes it's called digital phenotyping, smartphone sensing. Someone once called it smartphone phonotyping, which was pretty smart. It's actually a better word for all of it. And in considering that to build an individual model, say to predict what's happening to John or to Laura, you need a lot of data. What do you see as the future of kind of these just-in-time adaptive interventions? Are we close? Are we far? Do we have to take some step backwards? This is a big question. We won't solve
Yeah.
it all here, but it's a good
Yeah.
question.
Yeah, I think it's a great question. I think the eating disorder field is just starting to get into this space. I've seen, some digital phenotyping in other spaces, predicting depression, um, and anxiety. But, in this space, I think we're just starting. There have been some students actually in my lab who have done a bit of this work building machine learning models to, accurately predict engagement in eating disorder behaviors based on heart rate variability and things like that. I can't speak on the ins and outs of how difficult that was, and what the challenges are of achieving predictive accuracy, but I think there are many, and I agree that you are dealing with potentially some very noisy data in some of those biobehavioral data sets.
Yeah, it's tricky, but as you said, if you realize we're at the beginning and we actually are making very rapid progress, if you look at how usually treatments get developed, that is encouraging. This is an interesting question, saying a lot of what we talked about today is kind of for people who want help or seeking help, but sometimes people with these disorders don't realize they need help or may actively, again, resist help. That's part of what makes these illnesses so dangerous and so tricky and so severe. Do you think there's anything that we can be doing to kind of help people that actively don't want help because of the illness?
Mhm. Yeah, that's a really interesting question, and it's one that it's very real for in the context of eating disorders that are very egosyntonic, right? So these are not people that are distressed by their symptoms. Um, yeah, I think certainly I've been thinking a little bit more creatively about how to get some messaging across, um, in other places that people might frequent inside and outside of healthcare systems. Messaging on social media that could promote the idea of like how to know that you might have a problem with one of these things, some motivational interviewing, but ultimately it's going to be really hard to make a difference until those folks are actually interested in seeking treatment. Having said that, though, if they do take even a very first step, like taking a screen, right, we can intervene pretty early up the stream, as I was demonstrating earlier, with some motivational interviewing or other techniques via a chatbot or some other tool like that. So I think that can make a big difference.
And this question is related to screening. Again, I learned from a very smart doctoral student in our team about the MSCOF as a way to screen for disordered eating, not an eating disorder. Are there any other screeners that you think are interesting or people should look at or consider as good tools?
Yeah. Yes. So one screening tool that I think is good is the Stanford Washington University Eating Disorder Screen. It's very brief. It's validated. It's actually the one that is used on the NIDA, public facing online screen. So I think that's a great one.
Yeah. And this is a comment, not a question, but it says a helpful resource for Canadians is NEDIC, the National Eating Disorder Information Center. Maybe it's pronounced NEDIC. I'm not sure, but National Eating Disorder Information Center for Canada, spelled CENTRE. And this is, I don't know actually the answer to this question. Maybe if you don't, Laura, I have an idea, but recommendations for excellent mindfulness guides that focus on eating disorders in children. That's a hard one. I will say our team at Beth Israel has a website called mindapps.org, mindapps.org. We index different mental health apps that are about $10 or less, and you can filter them by eating disorders. You can filter them by mindfulness. We don't have a youth filter because that's hard to define what it is, but I think mindapps.org, I'll put it, can at least give you something to explore with and play with it. But I don't know if there would be one at that intersection. It's definitely a good point or question to bring up of it. So I'll put mindapps.org as one way to find these mental health apps. Again, on this website, we don't endorse any app. We just have given you a way to search them instead of typing in eating disorders or mindfulness into the iTunes and Android store. And who knows what comes up, because we've talked about before, a 5-star app means it's more popular. It doesn't mean it's going to meet your needs. It's going to be more private. It's going to be more evidence-based. The app stores are consumer marketplaces, and we hope mindapps.org gives you a more informed way to search for an app that may meet your needs. But I think we may break here because we try to keep this exactly at half an hour. So I think we've met our goal. And thank you, Laura, for sharing so much about kind of the scope of the field, what you're doing, where we could be going, some of the AI pluses and minuses, and answering quite a range of questions. And of course, thank you to our audience for partaking. We'll see everyone next month. And I think we may have a Australia-focused series coming up that will be on Australia time for all of our international listeners. So thank you to everyone. Bye.
Thank you so much.